Dear colleagues, welcome to my workplace at Ranaghat, West Bengal, India. This is Phaco emulsification of a cataract with grade 2 plus nuclear sclerosis. This is the main incision with a 2.8 mm keratome on the posterior aspect of the limbus. And now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The anterior chamber is filled up with this visco. This is a side port on the right side of the main incision, and this is another side port on the left side of the main incision. And now capsulorhexis is to be done. The anticapsule is incised with a 26 case bend needle. A flap is raised. I hold this flap with Utata forceps. The anterior lip of the main incision is kept lifted up, and the Utata moves all around, and this continuous curvilinear capsulorhexis is completed. And now hydrodissection is to be done. Ringal lactate or BSS is passed under the anticapsular rim. The fluid goes to the opposite equator. The nucleus is tapped. The fluid comes anteriorly along the equator, and the lens mass becomes separated from its capsule. Visco is again injected, and now is the time to introduce the tip of the Phaco handpiece. The machine being used in this case is Oatley Catarix 3 Phaco machine. Some superficial cortical matter is removed. Now the handpiece is turned, the bevel is made off, and now see how to chop this soft nucleus. Bury the tip into the substance of the nucleus, stop at the center, and slice the nucleus like this. Rotate it, slice it another place. Rotate. This is the endonucleus, and this is another good chop. The endonucleus is emulsified, and this nuclear fragment is emulsified. Ultrasonic energy used in this case is 50%. Flow rate is 40 ml per minute, and vacuum is 450 millimeter of mercury. One heminucleus has been removed. Now this is the other heminucleus having two pieces. And now this is the last nuclear fragment, emulsified and removed. Now this is the epinucleus. At this time we must not use high vacuum, must use very low vacuum to pull the epinuclear plate at the central area, and then just use vacuum to remove this. Minimal ultrasonic energy can be used, like 5% or 10% ultrasonic energy can be used for thick epinuclear shells. And now, by the time the assistant gets ready with bimanual irrigation aspiration, we can remove the inferior part of the cortex, say from 2 o'clock to 8 o'clock. This portion can be removed by the Simcoe itself. And now, with the help of bimanual irrigation aspiration, the cortex in the superior aspect is easily removed. Now this is hydro polish. The fluid jet is used to polish the posterior capsule. Now, a foldable intraocular lens is to be implanted in the capsular bag. In this case, I am going to use a B cartridge for implanting the lens, and it is a good idea to enlarge the main incision little bit. See how to enlarge the main incision. Keep the AC formed and just make 2 small cuts. Here it is. This is one and this is another one. Just 2 small cuts and the main incision has been enlarged to about 3.2 millimeters. Now this is the lens. It is a hydrophilic acrylic single piece monofocal intraocular lens, and it has been placed in the capsular bag. Whatever visco was there in the lumen of the cartridge is removed by irrigation and aspiration. At this time, the sight ports are being closed by corneal stromal hydration. BSS or ringalactate is used for corneal stromal hydration. And now this is the final lavage of the anterior chamber. At this time, some visco that sticks to the corneal endothelium comes out. Friends, this is a routine surgery, but what is routine for me is a challenging case for a surgeon who has just started surgery, say a few months back. And I want to hammer on your head the same thing, the same surgical principles on your head again and again, so that it settles in your head very firmly. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve the mankind with love, respect, compassion, and great surgical skills.